Hello, everyone. We might get started. I'm sure a few more people will join, but it might be worth getting started so we can finish on time. Thanks you all for attending this webinar. Welcome. Tonight's webinar is on medical imaging, referral modalities, and cancer diagnostic imaging pathways. My name is Nicolette. I'm a GP in Palmyra and am a member of the Cancer Council Education Committee and have the privilege of chairing tonight's meeting. So before I start, I'd like to acknowledge the traditional owners of the land, the Noongar Whadjuk people. I would also like to pay respect to their elders past, present and emerging, and offer my acknowledgement and respect to other Aboriginal and Torres Strait Islands to people who are present. Now, just start with the housekeeping. Please make sure your phones are on silent or off and your children are silent or off. So we encourage you to ask questions. At the bottom of your screen, you'll see the Q&A little comment bar. Just press that and write a question, and at about 7:45 we'll go through those questions. And at the end of the event, we'll send you an evaluation survey. We encourage you to complete this so we can continue to improve our education events we provide for you. Now, today's speaker, we're lucky enough to have Dr. Ravinder Dhillon. Ravinder Dhillon is a consultant radiologist at Charles Gardner Hospital and Breast Green, WA. She is a graduate of the University of WA and trained as a radiologist in the WA Inter-Hospital Training Scheme, followed by fellowship in breast imaging at the Royal Perth Hospital and abdominal imaging at the Vancouver General Hospital in Canada. Ravinder was awarded a Master of Science, Medical Science in 2007 from the Uni of WA for her research in radiology and thesis titled Diagnostic Imaging Pathways. She is the current Chief Editor of the Diagnostic Imaging Pathways, which is a very useful website-based clinical decision support tool and education tool. So I'll hand over to you, Ravinder, and then, as I say, we'll do some questions in about 45 minutes. Thank you.
Thanks, Nicolette. Good evening, everyone. So title of my presentation this evening is Medical Imaging, Referral, Modalities, and Cancer Diagnostic Imaging Pathways. I have following disclosures to make. As Nicolette mentioned, I'm the current Chief Editor for Diagnostic Imaging Pathways, but I have long association with Diagnostic Imaging Pathways project, starting off as a research fellow in 2003 and then serving in various capacities on the project, namely editorial panel, steering committee, deputy editor, and so on. The imaging recommendations that I'm making in this talk are based on diagnostic imaging pathways. As mentioned, they are evidence-based and consensus-based education and decision support tool developed for clinicians. These pathways have been developed in WA under the leadership of Professor Richard Mendelson, who's retired now, and we got funding for this project from Health Department. The editorial panel for diagnostic imaging pathways is quite broad. It includes various subspecialty radiologists, general practitioners, clinicians, consumer representative, and so forth. It is freely available on Imaging Pathways Health website. And starting off with my talk, the overview of my talk firstly starts with common diagnostic imaging modalities and their applications, the benefits and risks of various imaging modalities, and finally, what is a good imaging referral. For a radiologist, the main tools of the trade include radiographs, ultrasound, CT, MRI. And for a dual chain radiologist or a nuclear medicine physician, it includes nuclear medicine studies and including PET studies, and I'll be briefly mentioning these in my talk. Starting off with plain radiographs. Now, in plain radiographs, X-ray machine emits a small amount of radiation. This radiation passes through the body and gets detected on the detector to produce an image. So plain radiographs provide great detail where for bones, joints, and areas of body where there's substantial soft tissue difference in X-ray absorption. For example, in thorax, where there is marked X-ray difference between bone, lungs, and soft tissues. So plain radiographs are used to look for fractures, assess joint or spinal disease, and to assess for cardiopulmonary disease. Chest X-rays are usually performed for anyone with acute symptoms, chest-related symptoms such as chest pain, shortness of breath, chest trauma, and they're also used for oncological staging and surgical planning. In this chest X-ray, we can see there's a large mass in the right upper quadrant, in the right upper lobe, which is closely related to the mediastinum. On the other hand, abdominal radiographs is a different story. There are infrequently diagnostic, they're often non-specific and usually normal. And you can't use a normal abdominal radiograph to exclude significant disease, and so we shouldn't be using abdominal radiographs to ensure normality. So before requesting an abdominal radiograph for anyone with abdominal pain, one should carefully consider where does it fit into the diagnostic algorithm for acute abdomen. The main indications for abdominal radiographs include where we're looking for bowel obstruction, bowel perforation, where we're looking for foreign body, or in patients who have moderately severe undifferentiated abdominal pain. We can also use plain radiographs to follow up renal tract calculi, which have been detected on CT renal colic and are visible on plain radiographs. Here is an example of a small bowel obstruction as shown by multiple distended loops of small bowel. On the supine image and on erect abdominal radiograph, you can see multiple airflow levels and a string of pearls sign indicating mechanical small bowel obstruction. So benefits of plain radiographs are that they're readily accessible. You can perform them quickly, they're inexpensive, and so they're quite cost-effective imaging modality to use. But they do involve use of radiation. And for example, the radiation dose involved in a chest X-ray is in order of 0.02 millisievert effective dose, which is equivalent to 3 days of equivalent natural radiation one gets exposed to. In comparison, abdominal radiographs involve a radiation dose of around 1 millisievert, which is equivalent to 50 chest X-rays or 6 months of equivalent natural radiation. Whilst the CT scans, they use much higher dose, more than 5 millisieverts, and that can be equivalent to 2 to 5 years of natural radiation one is exposed to. Starting off with an ultrasound. Now, ultrasound works by sending a high frequency sound wave, which is directed at an internal body part, and this reflected sound or echo is recorded to create an image. The strength of the ultrasound lies in its ability to distinguish cystic from solid lesions. So we can use ultrasound to characterize lesions in various organs, whether that be liver, kidneys, pancreas, spleen, so forth. Here's an example of a hepatic cyst as shown as a anechoic well-circumscribed structure with posterior acoustic enhancement, indicating this is a benign hepatic cyst and it can be left alone. Ultrasound is also a modality of choice for investigation of gallstones and acute cholecystitis, and they can be used to assess biliary ducts in patients with abnormal liver function tests. Here's an example of acute cholecystitis on ultrasound. You can see echogenic stones within the gallbladder. The gallbladder wall is thickened and edematous, and there's a small amount of pericholecystic fluid. And these are the features of acute cholecystitis. With ultrasound, you can also assess the biliary tree at the same time. Ultrasound is indicated in all patients with lower urinary tract symptoms and renal insufficiency. It allows assessment of the upper tract for looking for hydronephrosis. You can determine post-void bladder residuals, And in fact, ultrasound is superior to IVP in detecting secondary changes of bladder outlet obstruction, such as bladder wall thickening. Ultrasound is good at diagnosing acute appendicitis. In this image, you have dilated, inflamed appendix in keeping with acute appendicitis, and there's an echogenic structure in keeping with appendiculolith in its tip. Ultrasound is quite useful for assessing pelvic pathology in young women with right lower quadrant or pelvic pain. And ultrasound is actually preferred modality for performing any image-guided procedures such as biopsies and drainages. So strengths of the ultrasound is it does not involve radiation. It is non-invasive, it's readily available, it is inexpensive and can be rapidly performed, and it can also diagnose alternative cause of abdominal pain. However, there are limitations to ultrasound. It is heavily operator dependent, and it is less accurate in obese patients. It is also less accurate in patients who have retrocecal appendix or perforated appendicitis. Moving on to computed tomography. Now, CT uses X-rays and digital computer technology to create detailed 2D or 3D images of the body. And unlike other imaging modalities, the CT scan can image every type of body structure at once, whether that be bones, blood vessels, and soft tissue. So CT, we can pretty much scan from head to toe, and is actually imaging modality of choice in patients with trauma. It can be used to assess patients with acute abdomen where we're suspecting diverticulitis, patients with acute chest pain looking for aortic dissection or permeambolus, and it is imaging modality of choice for looking for renal calculi in suspected renal colic patients. CT is a main workhorse and in oncology for detection and staging of malignancies, whether they're in the lung, esophagus, kidneys, pancreas, lymphomas, etc. Here's an example of a renal cell carcinoma. As you can see, there's a large heterogeneous mass centered on the right kidney and the normal kidney on the contralateral left side. This mass is actually extending into the renal vein and expanding it. But at times, it can be hard to see for a renal vein invasion on CT. In those cases, we'll do an MRI for such cases. Example of a triphasic CT liver study. Here you have a non-contrast study on the left, followed by arterial phase study and a portovenous phase study. As you can see, there's a arterially enhancing lesion on the arterial phase, which is not appreciated well on the non-contrast study or on portovenous phase study. So it is important to know what kind of tumor you're looking at or you're assessing, because they'll help you guide what kind of CT study you need to perform or what imaging you need to perform. Because if you're looking for vascomats and you do a single phase study, quite possible that you might not see these metastases on portovenous phase. So knowing some history is very helpful. This is the same patient we saw the chest X-ray of earlier, and it's a staging CT. Here we see a large heterogeneous mass, which is extending into the mediastinum. It's closely related to the adjacent spine and trachea. You can see a large lymph node in the right hilum and another nodule in the upper abdomen. And now, role of CT in lung cancer screening. Now, where studies have shown that lung cancer CT scanning for lung cancer screening is beneficial, but the Australian government is deciding on how best to implement this in our population. And lung cancer screening CTs are low-dose non-contrast CT tests, and they involve less than 1 millisievert of radiation dose. Current Medicare rebate is for symptomatic patients with smoking history. Briefly touching on CT colonography, or what we call virtual colonography. Now, in some nations in Europe and in New Zealand, CT colonography is used as a screening for bowel malignancy. In CT colonography, essentially, we evaluate the colon and rectum. Patients given bowel prep to cleanse the bowel, and then a rectal tube is placed, and bowel is distended with carbon dioxide. And we take CT images of the patient in supine and prone position, and with clever computer softwares, we can create images that are very similar to endoscopy. Here's a fillet view, and this is the endoscopic view. This is what the raw CT images are, and you can see there's a polyp in the bowel here. Usually, any lesions more than 10 millimeters show up quite well on this technique. Current indications for CT colonography in Australia are for evaluation of patients who could not have a complete colonoscopy. This may be in patients who have obstructive carcinoma and you want to rule out proximal synchronous lesion, or patients who are too frail or unsuitable to undergo colonoscopy. They may be medically unfit for sedation, or they may be on anticoagulants, or who have had a previous difficult colonoscopy. In those cases, those are the main Medicare indications in Australia. Various studies have shown that CT is quite beneficial. CT main strength lies that it is quite accurate. It's painless, it's non-invasive. It acquires images quite rapidly, so it's less sensitive to patient movement in comparison to MRI. It is cost effective for a wide range of clinical problems. It can be performed in patients with implantable medical devices, unlike MRI, where they may be contraindicated. It can image a small portion or all of the body, or whole of the body during the same examination. It is also great for guiding image-guided procedures such as biopsies and drainage. And studies have shown that CT improves medical management by improving cancer diagnosis and treatment and determining when surgeries are necessary. It helps reduce the need for exploratory surgeries and reduce the length of hospital stays. However, a CT does involve radiation exposure, and there's always a slight risk associated with any exposure to radiation. However, the benefit of an accurate diagnosis will generally outweigh the risk, and the effective radiation dose involved in CT varies with the type of the CT study being performed and what organ. In general, we do not recommend CT in pregnant women unless medically necessary because of potential risk to the baby. However, this risk is minimal in patients undergoing CT head. Moving on to magnetic resonance imaging. So MRI use magnetic field and radio waves to take images of the body. It is really good at imaging soft tissues such as organs, muscles, ligaments. MRI actually images water, whereas X-rays image calcium. So various organs in the body contain various amount of water, and this information is used by MRI to create images of many organs and tissues that are difficult to distinguish on standard radiographs. So MRI is superior at identifying soft tissue injuries such as spinal cord injury and ligamentous injury. It is imaging modality of choice for many brain and spinal cord conditions because of the superior detail. However, in emergency situations where we're looking for bony abnormalities or occult spine fractures, CT is usually recommended due to its speed and superior imaging of bone. MRI can be used to characterize lesions in various organs, such as liver, kidneys, pancreas. It can also be used to assess biliary tree. In this example, on a MRCP study, you can see a dilated biliary tree. However, there is a stricture in the common bile duct. On the image on the right, the biliary tree is dilated, and in this case, the cause is a obstructive calculus in the distal common bile duct. MRI is useful in staging and detection of malignancies such as prostate cancer, rectal cancer, certain breast cancers like invasive lobular cancer, which are associated with a higher risk of cancer in the same breast and the contralateral breast. So studies have shown to be beneficial in preoperative staging in invasive lobular breast cancers. Here's an example of a prostate cancer on a multiparametric prostate MRI study. On T2 axial images, there's a low T2 signal lesion in the left peripheral zone with a corresponding low signal on ADC images and a high signal on diffusion weighted images. So this lesion would be classified as PARADS 5 lesion, which is highly suspicious for a prostate cancer. Now, one of the questions sometimes I get asked is, what is PARADS? PARADS is essentially imaging, reporting, and data system to standardize reporting of multiparametric MRI prostates, and lesions are graded 1 to 5. 1 to 2 meaning very low or low risk of malignancy. Lesions characterized as 4 to 5 with a high to very high risk of malignancy, and PARADS 3 with an intermediate risk. Here's one of the algorithms for suspected or staging prostate cancer, where if you assess the patient for risk factors, ask whether their patients are symptomatic, and then GP assesses whether there's a high or low suspicion of prostate cancer. If there's a high suspicion, then patient gets referred to urology, who organizes these multiparametric MRIs if they are available where they are, and then further on these lesions get characterized as per PARADS, and algorithmic flow management follows as shown. So benefits of MRIs: it does not involve radiation, so it's a safer option in children and young adults. It provides better soft tissue contrast in comparison to CT, so it can differentiate better between fat, water, muscle, and other soft tissues in comparison to CT, which is better at imaging bones. However, MRI is expensive. It's less readily available, and the scanning times are longer. So at times, patients may need sedation or anesthesia to undergo MRI scan. Also, certain metallic foreign bodies or prostheses and implants, such as pacemakers, neurostimulators, dental implants, they are contraindicated to having MRI. But more recently, the newer implants and prostheses and pacemakers, they are safer in our new scanners. The issue with them is these structures can malfunction in MRI magnetic fields, or they can get displaced, and they cause a significant artifact on our MRI images. If they're embedded foreign bodies, for example, in eye, they can potentially move. And certain conductors or wires, pacing wires you might have, these can get overheated and cause burn injuries. And one needs to carefully consider MRI in patients who have hearing loss, because there's a loud clicking noise that can actually exacerbate person's hearing loss, although they are given hearing protection, but sometimes that doesn't prevent the hearing loss from happening. Claustrophobia is another issue. Some patient do not handle lying in the bore of the MRI scanner. Pregnancy, usually you would want to avoid performing MRI in the first trimester of the pregnancy, though there are no known adverse effects of MRI in pregnancy. Usually it's prudent to defer the MRI scan until after pregnancy, or at least after the first trimester. And MRI contrasts are relatively contraindicated in pregnancy. Lactation is usually not a problem, and it's breastfeeding is not contraindicated to having MRI or MRI contrast agents. Now, having a superior detail on imaging does not always translate to having improved outcome for patient. In fact, it can lead to detection of incidentalomas, which can lead to cascade phenomenon, and then and result in patient anxiety and more tests for the patient, which might not have caused any issues for the patient in their lifetime. Moving on to nuclear medicine imaging. Nuclear medicine studies, they involve use of radiotracers. And these traces are either injected, swallowed, or inhaled, depending on what type of study you're doing. They accumulate in area of the body under examination, and then you use gamma cameras to detect radioactive emissions from the radiotracer. And this cameras then produce images and provide molecular information of the structure. They used to diagnose and evaluate and treat many diseases, including cancers, heart disease, GI issues, so forth, and have the potential to identify disease in its early stages. In oncology patients, it's also used to assess treatment response. Positive emission tomography, part of nuclear medicine studies, and short called PET, is mainly used to assess cancers and heart-related disease. And the main radiotracer used for PET is F18 fluorodeoxyglucose, or FDG, which has a molecule structure similar to glucose. And the areas that are more metabolically active, such as fast-growing cancer cells, take up FDG and appear brighter than normal tissues on the images, and has allowed detection of disease, metastatic disease. These days, we can co-register PET imaging with CT or MRIs, and this leads to more precise information and accurate diagnosis. Example of a non-small cell lung cancer and PET CT study. Remember, this is the same patient we looked at the chest X-ray and CT of earlier. Here you can see uptake of radiotracer in the main mass. On the axial images, on the coronal images, there's uptake in the right hilar lymph node as well, and there's uptake in that nodule in the upper abdomen, indicating it's a metastatic disease. We had picked these on CT, and in addition, we can see there's actually a hot spot in the spine as well, so indicating osseous metastases in this patient. This is, these are collage of images from PSMA, PET scan. PSMA is used for prostate cancer imaging. Here you can see uptake of radiotracer in the right side of the prostate gland, also some uptake in the pelvic side wall lymph nodes on the right and on the left, indicating there's a possible metastatic disease in the pelvic lymph nodes. Benefits of the nuclear medicine study is they provide unique information, detail of the function and anatomy of body structures. They are less expensive than exploratory surgeries. They have potential to pick up disease early. They help distinguish benign from malignant lesions, and then can help eliminate the need for surgical biopsies. Or they can identify the best place to biopsy lesions if they're multiple metastatic lesions or suspected metastatic deposits. They help in radiation therapy planning. However, nuclear medicine studies do involve low-dose radiation exposure, and allergic reaction to radiotraces can be an issue. And they are time consuming. It can take several hours to days for the radio tracer to accumulate in the area of interest, and imaging may take up to several hours to perform. And the image resolution on PET CT or PET MRI is not as high as a standard CT or MRI. Before requesting an imaging test, one needs to give careful detail or take a good history and physical examination, because that helps us arrive at a provisional diagnosis. And this provisional diagnosis helps us decide whether imaging is indicated. And if it is indicated, what kind of test is indicated. And also this provisional diagnosis helps us decide what type of protocol we need to perform. Various studies from around the world, UK, Canada, Europe, including our own study, local study by Bastow et al., showed that around up to 30% of imaging performed in medicine is inappropriate. And what constitutes inappropriate imaging? For example, performing imaging when none is indicated, where it is not going to impact your diagnosis or management, it is inappropriate. Or choosing a wrong modality. For example, if you're looking for gallstones or acute cholecystitis, you request a CT scan, when ultrasound is an imaging modality of choice for gallstones and acute cholecystitis, and does not involve any radiation. At times, one might choose a correct modality, but perform a wrong protocol. As I mentioned earlier, in the case of a hepatocellular carcinoma, that cancer would have been missed on a single phase study. A triphasing, knowing what we're looking for, we can protocol the study properly. So hence the importance of provisional diagnosis. At times, correct imaging may be performed, but the timing of it may be wrong, and things might not show up on that CT scan or MRI study or whatever study you're doing. So that constitutes inappropriate imaging too. Not performing imaging when it's indicated also is inappropriate. And the causes of inappropriate imaging are often complex, and there are multiple. Knowledge gap being one of them. These days, technology is rapidly evolving. It is more complex. There are lots of choices. Keeping up to date is becoming difficult. Other times, it's the medical legal factors that drive doctors to perform lots of tests. The fear of litigation being reason behind. At times, it's the patient's expectations. A patient expects to be a blood test to be performed or a chest x-ray to be performed for a minor cough, and GP feels pressured to do so. At times, it's clinicians' time constraint. They're so busy, they're using imaging to triage their patients, which is a worrying concept. Imaging, there's a lot of people and doctors who these days think imaging is so good, why should I examine the patient? And this is a worrying trend, and I'll briefly touch on this a little bit later in my talk. Self-referral at times leads to inappropriate imaging. And these days, we have this perceived need to be certain. And we want to get imaging done just to be sure. And other times we fail in our responsibility to see whether that imaging is actually going to impact on patients' management or outcome, and we see, okay, oh, there's a mass there, we need to characterize. It might not be appropriate thing to do in a 90-year-old who's not doing very well to investigate certain findings. At times, we, the radiologists, fail in our responsibility as consultants and gatekeepers what imaging should be performed or not. This cartoon actually titled Modern Medicine aptly summarizes the issue of inappropriate imaging. Here, doctor is examining patient named Bob, says to Bob, well, Bob, it looks like a paper cut, but just to be sure, let's do lots of tests. This slide is from Peter Skelly's medical textbook titled Medical Imaging. You can see there's, what he's saying is on this slide is that imaging test helps us, or any kind of test helps us by either pushing the probability of disease above the action threshold or below the exclusion threshold. Above action threshold, one would be instigating treatment. Below exclusion threshold, one would be comfortable in excluding that disease. For example, for a streptococcus throat, one need not be 100% sure. One could start treatment even if one is 80% sure. But it's a different story if we are dealing with cancer. One ought to be 100% sure before instigating any treatment because it has implication in regards to management, prognosis, and patient psychology. And most imaging tests are useful in the middle spectrum between this exclusion threshold and action threshold. Why inappropriate imaging matters? Because they add to the risk of the test, which is ionizing radiation in case of CT without the added benefit of the test. It adds to the cost of the healthcare. It can result in delay in diagnosis, can result in incidentalomas and overdiagnosis, and they're a significant threat to effective allocation of health resources. Radiation, why worry? All international regulatory authorities now accept the no low threshold linear model. So essentially any dose, however small, carries a risk. And this risk is in the order of 1 in 1,000 excess lifetime risk of fatal cancer in patients undergoing multi-phase abdominal CT. This risk is much higher in children and adolescents or young adults, to the order of 1 in 300 to 1 in 500. And certain organs are more susceptible to local effects of radiation, such as breast exposure during CT study or thyroid exposure during cervical spine imaging. However, this risk is heterogeneous. It is age-related, much higher in children and young adults, and is often deferred by 10 to 20 years. This risk is cumulative. However, it remains small compared to background risk of cancer. So we need to err on the side of caution, not alarm, as the individual risk is small and patient should not be scared of having examination if it is important to their health and management. If the examination is justified, it should be performed. And before requesting any imaging study, one should adhere to the principles of justification and optimization. As per justification, we need to ensure that the benefit of the test outweighs its risk and ensure that the appropriate imaging gets done. As per optimization principle, which is based on a LARA principle, which is as low as reasonably achievable. And this risk versus benefit ratio is best assessed as a team, a radiologist and the referring clinician. Referring clinician knows the patient well, and the radiologist can guide what test is best for looking for a particular question. And moving on to this trend of why examine the patient when imaging is so good, it is worrying because it is abandoning the clinical paradigm. Imaging is not a substitute for the clinical paradigm. As per the clinical paradigm, good history and physical examination are important to arrive at provisional diagnosis, which determines a pre-test probability of imaging examination. And it also helps us decide whether we need to perform imaging, what kind of imaging needs to be done, and whether that it is going to impact the diagnosis or a management of patient. Is it going to do more harm than good? What imaging protocol needs to be performed? And of course, to help us decide what test to perform, we can consult with our radiologist. And these days, we even have decision support tools. And the significance of the result of a imaging test is very much dependent on the pre-test probability or the provisional diagnosis. So that history on their request card is very important and very useful to guide us as a radiologist how we can answer the question you have posed in best possible fashion. As per the optimization principle, which I mentioned, it's the responsibility of radiologists to ensure that the radiation dosage during imaging is kept to minimum according to ALARA principle, while maintaining the diagnostic and quality of examination. Here's two images. One is a low-dose non-contrast CT renal colic protocol on the left. Patient had presented with renal colic symptoms, and the CT scan shows a calculus in the left ureter. Patient was managed conservatively, however, presented 2 months later with similar symptoms. This time, for some reason, a normal CT scan was done. You can see the diagnosis is same. There's a calculus in the left ureter. Pictures are much nicer, less grainy than the other side, and you can delineate the calculus definition a bit more. The answer is same, but on the scan on the right, we have subjected the patient to 2.5 times the dose of a low-dose renal colic study. So better imaging does not always translate into better outcomes. To encourage appropriate imaging, obviously education is important, and adhering to the principles of justification and optimization is important. And we also have clinical decision support tools. And what's one such tool that, in fact, is the only tool that has been developed in Australia for Australian clinical environment. It's called diagnostic imaging pathways. The key features of diagnostic imaging pathways are that it's web-based, electronic format, it's non-commercial, freely available, it deals with common clinical scenarios, it has an algorithmic flowchart structure, it deals with all modalities, it has a layered format, so you can access as much or as little information. It includes teaching points, image galleries, information for consumer, and also hosts the ionizing radiation training module. If you go to the Imaging Pathways website, that's what the website looks like, and pathways are divided into various organs, and there are more than 180 pathways available. Cancer staging pathways are under this icon. If you click on it, it lists all the cancer staging pathways that are listed. They are included on this deep website. And if you click on the pathway, for example, if we clicked on non-small cell lung cancer, it takes you to the home page for their pathways. The radiation doses for various modalities have been indicated by radiation symbols as shown here. And when you click on the pathway icon, it leads to a pathway here, for example, for staging of non-small cell cancer. It starts off by doing a chest radiograph. And if you click on this red box, it gives you more information about that modality, how it helps in in staging of non-small cell cancer. And if you hover on this red box, it gives you a salient feature about that particular imaging modality or particular red box here about the CT scan. And you can access the teaching points by clicking on the teaching points. That it lists out the important points to remember in staging of that clinical problem. You can also access the images related to that particular pathway that show up under imaging icon. And you can access the references by clicking on references, and references have PubMed abstracts linked to it along with the reference. Consumer information can be accessed. Here's a consumer information in related to bowel cancer that you can access. So what I'm trying to stress is, before requesting an imaging test, give it a thought. Could please consider, is the imaging indicated for that clinical scenario? Would that imaging change the diagnosis? Would it change the management of the patient? Is it going to do more harm than good? Is there any previous imaging available which may prevent duplication of examination? And if the imaging is indicated, is there a non-ionizing alternative available, such as ultrasound? I'll stop there and take any questions. Of course, this is a website that imaging pathways are available
on. Thanks, Ravinda. That was such a good summary. I really appreciated that, because I find it really challenging to work out which modality to use often. If anyone's got any questions, you can pop them in now. Ravinda, can I ask you a question?
Sure.
With the radiation, that's something that really bothers me. And you see people that have had multiple CTs within very short periods.
Yes.
We don't formally consent for the radiation. Whose role do you think it is, the GPs or the radiologist, or both?
Essentially, it's a role. We perceive the test is being requested by a clinician, and clinician is knows the patient well, what we're looking for it, and can justify that test. The radiation doses involved with various tests are easily available. That's not an issue. And if you think that diagnosis, getting accurate diagnosis, is going to help manage your patient well, then that test should be done. And as you can, it can be easily explained to the patient, the radiation risk is small. But if you're going to be doing CT scan for every little problem, then it's for patients with Crohn's disease, you're exposing them to so much radiation, and one needs to be carefully consider is, can this be avoided, or an alternative test can be done to reduce radiation exposure? Yes, I think we normally in a teaching hospital, the clinicians are consenting patients for radiation for it, whether that be verbal or written. These days we are tending more towards a written consent. And in hospitals, we see that as a responsibility of clinicians. But of course, the radiologist is available there for consultation, and we are there to help. And again, clinical decision support tools, exactly the reason they have been developed, to help guide. And if there are any certain questions you need to seek, the information's a click away. Yes.
Thanks. We'll answer Stefan's question. He's asked what imaging is advised to check for microscopic hematuria.
Again, there's a pathway available on Imaging Pathways website. It deals with whether that's a painless hematuria or painful. But ultrasound is a good modality to start off with. And then whether there's a suspicion for stones, then low dose renal colic study, or if you're looking more for, correlating with PSA. So CT renal colic is a good study, and if we haven't found answer on it, then a CT IVP is another way. But there's an imaging pathway that is available on it, and I'll encourage you to use it.
Thank you. Aru has a question. In situations where a patient comes in with a lingering cough with a history of smoking and exposure to dust, asbestos, etc., would you consider a chest X-ray to begin with, or do you think that a CT chest is more appropriate?
Traditionally, we have done chest X-rays, but these days, chest X-ray is a good modality start of it. But if you have access to low-dose CT studies, that's a good start.
Thanks. Can I ask another question? Occasionally, you'll order a test and the radiologist will change it, because they've got a better idea that there's a more appropriate test. And I understand that they can do that. What are the rules around that?
Usually when we think a different test needs to be done, or it's usually done in consultation with the GP or the physician or the referring clinician. So it's a discussion between the radiologist and clinician. Look, you've provided me this history. I feel this is a better test. Is there any other particular reason you were thinking of this test instead of? So we're here to suggest, and it's a joint responsibility of a radiologist who's performing that test and the clinician who's requesting that test. As I said, to assess the risk-benefit ratio, it's a combination of the two. It's a team effort.
Does anyone else have any other questions they'd like to ask? I'll ask another one, sorry. I may as well, I've got your attention. Yeah. With pelvic ultrasound, yeah. Often there'll be a woman that doesn't want to have any, transvaginally. Mm-hmm. Is it worth doing it abdominally, or is it much less useful? Like, are there still benefits?
It depends on the body habitus of the patient as well. If they're a large woman or obese women, the information you're going to get is less. But it's still worth doing a trans-abdominal study. Yes, we get a better information with transvaginal pelvic ultrasound study. But if the women does not want to undergo a pelvic endovaginal scan, obviously, then we have to deal with it. But normally we have a little chat with them and say why we need to do it. And most of them do understand it. And once explained to them, they think if we can get more information, then they actually agree or consent to have an endovaginal examination.
Okay. It's almost time. I don't think there are any other questions other than comments. Here we go. Aru again. MRI, is it any good for paranasal sinus disease?
I would encourage you to do CT study. That would be the imaging modality for paranasal sinus disease.
It's just too expensive when a CT is probably better.
You can get better information. You can assess the bones better, and you're going to see the soft tissue mucosal thickening quite well in CT. So paranasal disease, CT is a modality of choice for that.
Okay. Well, if there's no further questions, thank you very much, Ravinda. That was a really, really useful summary. And thank you to everyone else who has joined in. As I said, everyone will get an evaluation sent to them. If you could fill that in, that would be great. And everyone can go and enjoy the rest of their evening.
Thank you very much, everyone.
Thank you.